Good evening. Today we'll be discussing about chest wall and lung injuries. Yeah. The most common injury following blunt chest trauma is rib fracture. Blunt trauma consists of 8% of the cases, and penetrating trauma consists of 7% of the cases. 40% of the patients sustaining thoracic trauma can be effectively managed only by tube thoracostomy, which we discussed in detail in the previous session. And thoracotomy will be required in 7 to 15% of the patients. And 30% of the patients undergoing thoracotomy, they require pulmonary resection. Mortality is quite high. It ranges between 5 to 45%. The main treatment modality is in thoracic trauma is first is multi-modal analgesia. Proper painkillers are to be given. And next is pulmonary toilet. That is, if any hemorrhage is present, it has to be removed. The traditional treatment of both rib and sternal fractures includes, just a second, I'll be used to includes limited to pain control with narcotics, internal pneumatic stabilization with mechanical ventilation in selected patients. Contemporary management, the recent management is multidisciplinary approach and protocol-based approach. It involves local regional anesthesia and proper pain control, non-narcotic oral and intravenous adjuncts. So what they found was when they used narcotics, most of the patients, they went to dependency and addiction to narcotic substances. Then surgical stabilization, that is SSRF, surgical stabilization of rib fractures, is the newer modality of management of rib fractures. So SSRF, if you see, the previous generation surgeons, most of the previous generation surgeons, they're totally against rib fracture fixation. I still remembered when I was doing my internship in my previous hospital during MBBS times, we used a dynaplast to splint the ribs. And many people, even now, many hospitals, they follow this technique. They use 3 dynaplasts just to fix the rib. My friends, that is a thing which you are not supposed to do. Never splint the ribs. So what happens is when you just splint the ribs, you're actually restricting the movement of the ribs, which leads to atelectasis of the lung. So the newer modality is SSRF, that is surgical stabilization of rib fracture. Now, currently, almost 7% of the patients with 3 or more rib fractures undergo SSRF. So what happens is when there is painful motion at sternal or rib fracture sites, it impairs respiration, it increases the risk of splinting, it leads to accumulation of secretions, it leads to pneumonia and respiratory failure. So the main message is don't use a dynaplast to splint when you have a rib fracture. You need to control pain, analgesia, and you need to consider other modalities. That is a multimodal approach. So coming to the anatomy of the ribs, the basic anatomy. So we have 12 pair of ribs. One second, I'll just. So there are something called true ribs and false ribs. True ribs and false ribs. So the first 7 ribs, 1, 2, 3, 4, 5, 6, 7. These ribs, they have their own costal cartilage and they directly articulate with the sternum. So these are the ribs, these are the costal cartilages, this is the sternum. So when the ribs, the first 7 ribs, they articulate with the sternum, they are called the true ribs. So 1 to 7 is the true ribs. And moving on to the false ribs, that is 8, 9, 10. The 8, 9, 10, they are attached to the 7th costal cartilage. They don't directly articulate with the sternum and they are called the false ribs. And there is something called floating ribs, that is the 11th and the 12th. 11th and the 12th ribs are known as the floating ribs. Okay. Now there is something called another terminology is typical and atypical ribs. Typical and atypical ribs. Atypical ribs. So what is a typical rib? A rib, actually, if you see the anatomy, it has a head, it has a neck and a body or the shaft. So if you see the rib, inferiorly, it has an articulating facet, which numerically corresponds to the vertebra. So it posteriorly articulates with the vertebra and it numerically corresponds. For example, if this is the 3rd rib, inferiorly, it articulates with the T3, that is the 3rd thoracic vertebra. And superiorly, it articulates with the vertebra above, that is the T2. If it's the 3rd rib, it articulates with the T2. And here there is a tubercle which numerically corresponding to the vertebra, it articulates with that transverse process of the numerically corresponding vertebra. So here you can see how it articulates. Here the body articulating with the numerically corresponding vertebra, and at the neck, the tubercle articulates with the transverse process of the numerically corresponding vertebra. So a rib which has these features is called a typical rib. So what are the atypical ribs? Atypical ribs are ribs 1, 2, 10, 11, and 12. So these are the atypical ribs. So these ribs do not have a typical feature of this typical ribs, which I told you. For example, the first rib, if you see it doesn't have a superior articular facet. It doesn't articulate above the vertebra. So it doesn't correspond. So it doesn't have the typical features. Similarly, 10 also has a single articulating facet, and 11, 12, they are floating ribs. So these are atypical ribs which does not have the typical features of the vertebra are known as atypical ribs. So we should know what is true ribs, false ribs, and what is typical ribs and atypical ribs. So most chest wall scoring systems are limited to the number of ribs fractured and the presence of bilaterality. Now, the Chest Wall Injury Society conducted Delphi consensus, and they addressed multiple rib taxonomical issues. So the basic thing for consensus, the basic consensus which they found was to see the first is location. The fracture location has to be defined. Degree of displacement. Associated fracture in the neighboring ribs. And flail chest, if there is flail chest or not. Flail chest or not. So location, degree of displacement, associated fracture, associated neighboring rib fracture, and flail chest. So any rib fracture, it has to be defined in these terminologies. So moving on to location. Location of the rib fracture, it can be either anterior, it can be either lateral, or it can be posterior. Depending on the anterior axial line or the posterior axial line, you can just define whether it is anterior, lateral, or posterior. Very simple. Next, moving on to the degree of displacement. So if there is a rib like this, now there is a fracture. So we see the degree of displacement. If the degree of displacement is just 0 to 9%, it is called a non-displaced fracture. Okay. And if the degree of displacement is between 10 to 99%, that is 10 to 99%, it is called offset. Then displaced fracture is if the degree of displacement is 100%. If it is completely displaced, for example, if it is like this, then it is a displaced fracture where there is more than 100% displacement. So flail chest. Moving on to flail chest, there is both clinical fail and radiological fail. So clinical flail chest is defined as paradoxical motion of a portion of the chest wall with respiration due to multiple consecutive ribs fractured in more than one location. So when you breathe in, the normal chest should expand. So it is a paradoxical movement. So when you inspire, the chest goes inside. That is paradoxical movement. Or when you breathe out, the chest wall comes outwards. So there is a paradoxical motion which is known as the flail chest. So the radiological definition is 2 or more consecutive rib fracture in 2 or more places. So some books, they have also mentioned that. So there is another definition described by Edward et al. He described as the radiological definition is 3 or more ribs fractured in 2 or more places. So this is also the definition found in Bailey also. But the most commonly accepted is 2 or more consecutive ribs fractured in 2 or more places. So this is known as the radiological flail chest. Coming on to the various scoring systems. Here we have the rib fracture score. Then CTS is the chest trauma score. Then this is the organ injury scale. So these are the various scorings present. The rib fracture score is it is most detailed, and it has been validated most extensively. So it includes number of ribs fractured, flail chest, bilateral fractures, degree of displacement, fracture location, and first rib fracture. Anyone who can tell what is the importance of the first rib fracture? Last class I told. So what is very important in the fracture of first rib? Anyone? So basically, in the first rib fracture, the vessels, subclavian vessels, they pass above the first rib. So there is increased uh, morbidity and mortality if the first rib is fractured. You need to look for vascular injury and also brachial plexus injury if the first rib is fractured. And they have also found that if there is greater than or equal to 6 rib fracture, the mortality is considerably increased if there is more than 6 rib fracture. Then there is another. This is a chest wall scoring. This is a dynamic assessment. Dynamic assessment includes the physiological response to chest wall injury. So this is a SCARF scoring, which is known as sequential clinical assessment of respiratory failure. So in this, they have respiratory failure greater than 20. Numeric pain score, that is out of 1 to 10, the pain score is if it is more than or equal to 5. Then inadequate coughing present and greater than 50% predictive incentive spirometry. So this is the dynamic part of the scoring. So if the patient has less than 50% of the predicted incentive spirometry, the vital capacity is measured here. And if it is less, then this is also part of a dynamic scoring, SCARF. So a patient who's having a thoracic trauma, first you need to go for initial evaluation and risk stratification. It is same, the previous class I have told, first you do a primary survey. First is hemorrhage control and the C-spine clearance. Then ABC, airway, breathing, and circulation. Then includes DEF, also disability and exposure also has to be done. So this is the primary survey. And very important part of primary survey is examine if there is any pneumothorax. You need to percuss the patient, you need to auscultate the patient. If there is a tension pneumothorax, you need to find during primary survey itself and solve the issue. Secondary survey is head-to-toe examination. As discussed, we have discussed the mnemonic sample, which includes allergy, medication, past history, last meal, and event history. So this is secondary survey, which we have discussed previously. Moving on to investigation, you do a EFAS examination, you do a chest X-ray, you see various findings. Then CT is recommended in some, the specific indications for CT is if there is 3 or more fractures visualized on chest X-ray after blunt trauma, and you require a CT chest for another reason. For example, you're suspecting abdomen injury, yes, you're doing CT abdomen, and patient is also having a chest pain, then also you do a CT chest. Physical examination discordant with chest X-ray, then also you do a CT chest. So these are the indications for doing a CT scan. So typically a CT scan, you need to have this kind of marking. You need to see for especially scoring of rib fractures, you need to see whether anterior, lateral, or posterior. You need to mark which ribs are fractured. You should also mention whether it is displaced, non-displaced, or offset. You should also see for hemothorax and pneumothorax. So these are the things which we will be seeing in a CT scan. So moving on to the admission algorithm. So when should you admit a patient or not? So when a patient comes in outpatient, you do an incentive spirometry. Ask the patient to do incentive spirometry. You give paracetamol or the acetaminophen 6 hourly. Ibuprofen that is NSH should be given 6 hourly, and a diazepam and oxycodone. Anyone knows what is PRN? You must be seeing this. Anyone what is PRN? Okay, PRN is pro-re-nata. Pro-re-nata is nothing but SOS. SOS. So whenever, you can give it, if the pain is increased, you can give diazepam or oxycodone. So even after you give all these drugs, you need to admit if the patient pain control using this algorithm. So if this respiratory rate more than 18, if the incentive spirometry is less than 75% predicted score, if the numeric pain score is greater than 5, or poor cough, age greater than 65 years and greater than or equal to 3 fractures. So if greater than or equal to 2 of these criteria, then you need to admit the patient. Then to admit the patient in SICU or in high dependency unit, you need to, if high dependency unit is if one of these are there and 2 of these in ICU admission, that is if age greater than 65 years, greater than 6 fractures, if the incentive spirometry is less than 60% predicted, if there is a flail chest, greater than 4 liters of oxygen requirement to maintain a saturation of greater than 90%, associated injury requiring PC or ICU admission, and then the surgery staff discretion or the consultant staff discretion, you can admit in ICU or not. Then if you see, this is actually somewhat similar to the scarf scoring also, if you see. That is, in scarf score, it is respiratory rate greater than 20, instrument is spirometry less than 15% predicted score, numeric pain score greater than 5%, and poor cough. It is something similar to scarf, if you see. You can remember that way. So if any of these things, then you can do a step 1 and step 2 according to the injury. Next, the important thing is multi-modal analgesia. So whenever a patient comes with pain, first you need to give same acetaminophen and NSAID. That is paracetamol and NSAID initially 6 hours you need to give. Then diazepam and oxycodone, that is SOS. And you can give 2 doses of IV narcotic push, maximum 2 you can do. But if there is greater than or equal to 2 doses given of narcotic, that is any ketamine or fentanyl is given, then you need to move on to the tier 2 category. The tier 2 category, it involves pain pump, liposomal bupivacaine intercostal nerve blocks, or erectrospinal catheter. So these are the things which should be tried. This is IVPCA. IVPCA. Then, anyone who knows what is the full form of PCA? Sorry, PCA. What is the full form of PCA? PCA is nothing but patient controlled analgesia. Patient controlled is actually patient will be having there will be a pain pump and patient will be having a button in his hand. So whenever the patient has increased pain, he can click it. So for example, the settings, the usual settings in our hospital is in a half an hour, he can press it once actually. Only the dosage, the bolus dose per half an hour is only one. So even if he clicks twice or thrice also, at half an hour intervals only, the bolus dose will be given. So this is known as patient control anesthesia. So whenever a patient is having increased pain, he can have a patient control anesthesia. So tier 2, after tier 2, we go to a tier 3. Tier 3 consists of narcotic PCA. Usually we give a fentanyl and bupivacaine combination in narcotic PCA. You can give ketamine infusion and lidocaine infusion. We need to understand that whenever we move on to from tier 1 to tier 2 or tier 3, it depends on the SCARF score. So initially you give the tier 1 painkillers. If the pain is not controlled, then you go to the next tier. That is, you use the SCARF score. That is, you see the pain score, you see the incentive spirometry, if the respiratory rate is more than 20 or poor cough. So if it is more than or equal to 2, if it is positive for SCARF, then you move on to tier 2. Then you move on to tier 2 and tier 3 accordingly to the pain. We need to understand that epidural analgesia, then USG guided erector-spinae and paravertebral catheters, they irrespective of coagulopathy, even though if the PTNR is increased or APTT increased, you need to use proper analgesia. You can give the analgesia irrespective the patient has coagulopathy or any anticoagulation issues. Next, moving on to SSRF. SSRF is nothing but surgical stabilization of rib fractures. The previous generation, many people still don't believe in SSRF, that is a rib fracture fixation. But I will tell you, we are actually personally seeing phenomenal results with SSRF. We are getting patients of rib fracture. So usually what happens is patient has chronic pain of more of a year, 2 years pain, and they suffer in rib fractures due to, the previous concept is that you don't need to fix the ribs. But now the newer concept is that you fix the ribs, the pain gets reduced, the movement is fast, you prevent atelectasis of the lungs, and there is fast recovery after rib fracture fixation. So moving on to the indications of SSRF. Patient with multiple displaced rib fracture in the absence of flail segment may also benefit from, flail segment is an indication. It is 3 or 2 or more rib fracture in two or more consecutive rib fractures in 2 or more different places. That is an indication for SSRF. Even multiple displaced rib fracture, even in the absence of flail segment, may also benefit from SSRF. Several prospective data have included patients with 3 or more bicortically displaced fracture, along with patients with a flail segment, are indications for SSRF. Then multiple non-displaced fractures non-displaced, and particularly who worsen clinically, and they may need actually a CT after 48 to 72 hours. So we need to access for interval displacement. So what happens is initially the fracture is not displaced, but due to some movements in the hospital or what it can get, the fracture would become displaced, and there a patient may need surgical stabilization of the rib fractures. SSRF in the situation, should be considered case-by-case basis. In the setting of poor response to multimodal analgesia, then you need to consider rib fracture fixation. So what are the potential indication for surgery, including which includes for SSRF is 1 or 2 painful clicking mobile rib fractures in a highly functional patient. If the patient is an athlete, even one rib fracture, if it is causes severe pain, then also you can fix the ribs. Then rib fracture impalement of internal organs. So the rib fracture internally can, it can cause a lung contusion. So there also you need to do a SSRF. So if it causes impalement of internal organs like lung, diaphragm, and spleen, you need to consider SSRF. Then on the way out of thoracic cavity for other indications. So if the patient is having a hemothorax, you have gone inside, you have removing the clots. Now you realize that there's a rib fracture. Even then, on the way out of the thoracic cavity, also you can fix the ribs. Then following elective rib fracture or removal, as in the case of thoracic spine exposure. So if there's any spine exposure, you're doing elective, we are going inside the thoracic cavity. Even then you can, while on the way out, you can fix the ribs. So coming to pulmonary contusions. Previously, pulmonary contusion, they thought that you are not supposed to interfere. You don't need to fix the ribs. But the newer concept is that even mild to moderate pulmonary contusion, you have to fix the ribs. Then pleural space infection has been considered a contraindication to rib fixation due to risk of postoperative infections in the implanted hardware. So even, even if there is infection, a clear empyema, we try to avoid rib fracture fixation. But even then, there are some studies suggested that even successful fixation has been done, and there is complications present in less than 5% of 5% of the population. Next, moving on to the geriatric population. Geriatric population, initially, they thought that, the patient would not be fit for surgery. So unnecessarily, we don't need to fix the rib. But now they have found that geriatric population, they actually even more benefit compared to younger population. The main reason for it is the atelectasis is caused by, due to pain. Patient actually has severe pain due to rib fracture. That causes atelectasis of the lungs, and recovery is very slow in them. So geriatric population, they recover much faster after a rib fracture fixation. So when rib fracture should not be performed. So in general, patients who will require long-term mechanical ventilation for reasons unrelated to chest wall injury will not benefit from SSRF regardless of the pattern of rib fracture. For example, a patient is there in a ventilator, he is having a traumatic brain injury, or he is having a high spinal cord injury. He is having anoxic brain injury following cardiac arrest with some period of cardiopulmonary resuscitation. So all these conditions, you know that he won't come out of ventilator. And the reason is not because of the rib fractures or the thoracic cavity, is some other reason. Then you try to avoid it. You try to solve the primary issue there, and then you may think of SSRF after you solve the primary issue. Now, then other things where you should not do SSRF is patient is in shock. You need to actively resuscitate the patient. You go by the damage control principles. You first treat the shock. The patient is having intracranial hypertension, unstable spinal injury, rupture of the thoracic aorta, inability to position the patients. For example, a patient is having pelvic trauma, implanted devices. So all these things, you can't turn the patient. Then also you avoid it. You initially fix the other issues, and then you come for SSRF. So when is SSRF recommended? When is the rib fracture ideally to be done? So it has been recommended that ideally it should be done less than 48 hours. So the initial patient control analgesia, all this multimodal analgesia, you do this multimodal analgesia, you monitor the patient for 12 hours, 12 to 24 hours, you see the patient. If the patient analgesia is not controlled after all these multimodal analgesia, then it is ideally the rib fracture fixation. The benefits of rib fracture fixation is ideal when you do it less than 48 hours. Some surgeons, they do it little later, but it is always recommended that less than 48 hours, you do the rib fracture fixation. Coming to the SSRF operative technique, this is in our institution, we have actually done a rib fracture fixation. Here we are having a multiple rib fracture of the left side. And here we are fixed with a universal plate and screws. So the principles of rib fracture fixation is ribs 3 to 10 should be considered for repair. If you see 1, 2, 3, it's very difficult to assess 1, 2, 3. And ribs 3 to 10, they maximum contribute to the movement of the thoracic cavity. The thoracic, during respiration, ribs 3 to 10, they maximum contribute. So you need to fix ribs 3 to 10. 1, 2, 3 is not needed. 11, 12 is just floating ribs. You don't need to consider. Sometimes, rarely, what happens is if 11th and 12th rib is impinging and it causes impinging on the liver, spleen, or it's causing some diaphragm injury, then what you do is you just remove the complete rib, 11th or 12th rib. You don't fix the 11th or 12th rib, you just completely remove the 11th or 12th rib. Okay. Practically, then fracture within 5 centimeters of the transverse processes. So if this is the vertebra, and if this is the transverse process, and here you have the ribs, if it is within 5 centimeters, if this is within 5 centimeters, it should not be repaired because the exposure required and the stability afforded by the overlying muscles and ligament in this area likely mitigate any additional benefit from surgical fixation. And it's very difficult to approach that area. So in this less than 5 centimeters, practically it is not possible. So you don't need to fix if it is just posterior, very close to the transverse process of the ribs. Now, what are the various positions? So depending on the position, where first you do a CT scan, you do a three-dimensional view, you see exact position of the rib fractures. Now, depending on the position, for example, if the patient is having a lateral rib fracture, you usually place in a lateral decupitous position. In anterior rib fracture, you place the patient in the supine position so that anterior ribs can be easily visualized. Then for posterior rib fracture, you keep in a prone position. And here you can see how the arms are a little bit at a lower position. So that actually causes the scapula to move laterally. So you can assess the posterior ribs. So usually in a lateral rib fracture, usually give a longitudinal incision. Longitudinal incision usually just anterior to the latissimus dorsi. It is just not important depending on the location of the it's just not the importance of the location of the rib fracture. You also give for giving the incisions, you also give importance to the muscles in the thoracic cavity, like latissimus dorsi and serratus anterior. You give incision according to the muscles also. So for a lateral rib fracture, usually we give a longitudinal incision just anterior to the latissimus dorsi. For anterior rib fracture, we give an infra mammary fold incision, oblique incision along the infra mammary fold. So this is the thoracic. Infra mammary fold, you give an oblique incision. Okay. And for posterior rib fracture, you can give a prone push. In a prone push, you give an incision, transverse or longitudinal incision. Usually a longitudinal incision can be given for a posterior rib fracture. In a posterior fracture, we usually enter the auscultatory triangle of auscultation. Anyone can tell me the borders of triangle of auscultation? Anyone, the border of triangle of auscultation can you tell? So here, this is the trapezius, this is the latissimus dorsi, and this is the scapula. So this is the triangle of auscultation. Usually at the posterior fracture, patient in prone position, we give a longitudinal incision here, and then we approach the ribs. But usually a patient who's having a flail segment, patient may be having an anterior rib fracture, lateral rib fracture, and posterior fracture. So in that type of condition where you have all these or multiple segments fracture, then you give a posterolateral thoracotomy. Then you have an access to all the places, anterior, lateral, and posterior. So usually for a lateral rib fracture, if you see, this is the here there is a longitudinal incision has been given. This is the latissimus dorsi. This is the latissimus dorsi. You retract the latissimus dorsi, and here you can see the serratus anterior. This is the serratus anterior. So you retract the serratus anterior, either serratus and the serratus anterior is inside along the muscles, and then you approach the ribs. So you usually retract the latissimus dorsi. You go anterior to latissimus dorsi. You retract it. Then you cut the serratus anterior along the muscle line. Then you see the ribs. So this is how you approach the ribs. Now the surgical techniques. We use different kinds of plating to fix the ribs. The most commonly used, what we use is the universal plate, which is 1.5 mm thick. First, so the basic steps of rib fracture fixation is first, you expose the ribs with techniques which I have described. Second, you measure the rib thickness. A universal caliper is used. We see usually it is either 8 mm to 1 centimeter. So you measure the rib thickness. You use a universal caliper for it. Then if there's a broken segment, there is something called reduction forceps like this. So you reduce the rib fracture using the reduction forceps. Then you need to shape the plate. So use something you use called bender pliers. This is the bender plier. This actually is manufactured by the Synthase company. So they have a this bender. So here you can bend it according to the shape of the ribs. And next, you position the plate. You use something called plate holding forceps. With the plate holding forceps, you fix the plate on the ribs. The next step is you drill it. So what you do is that this is actually the drill guide. You place the drill guide, you screw it onto the plate. Then you use a drill. You use a 2 point. Then this is the drill bits. First, you drill it with a drill bit, and according to the size. So initially, we have measured the size of the ribs, and depending on the size, we accordingly we have the drill bit size, and then we drill inside the ribs like this. Then we confirm the rib thickness. You can use a depth gauge. This is a additional procedure. You may or may not do it. Then the next step is to insert the screw. So you have a self-retaining screwdriver blade, and this is the handle, screwdriver handle. Then you rotate and fix the screws with the plate. Ideally, it is recommended that at least 3 screws in each side of the fracture. So this is the fracture, 3 screws this side and 3 screws the other side. It is minimum recommendation is 3 screws. 3 screws have to be used on the either sides of the fracture. The newer techniques they have also described intramedullary splints, which we are not using it. What we use is the universal plate, but intramedullary splinting has also been described, which has also been practiced. Then moving on to the sternal plates. Sternal plates are this is the size of the sternal plates. Initially, if you see from 1943, initially for sternal fixation, a K-wire was used. Now we have started to use a sternal plate. Only thing important is which you need to know which side you have to place it. So the side which has been edged, or this the crown surface, that is the smooth surface, is supposed to be facing towards the surgeon, and the other surface is supposed to face towards the patient, and then you fix the ribs. Now the newer technologies, this is actually is getting introduced in India. It is used in Western countries. We are having a drill like this shape. The advantages of a drill shape like this is that you can even you can even fix ribs behind the scapulas. For example, any rib fractures behind the scapula is very difficult to access it. So a drill shape like this can actually access difficult locations, and then you can fix the rib. So this will actually come to the market in another few months in India. This is being used in the Western countries, and you can also see the plate holding forceps. Plate holding forceps also curved in such a manner that you can access difficult locations. These are newer technologies which are being introduced. So what are the complications of SSRF? If you see, the incidence and complication is only less than 5%. But being a newer modality, the long-term follow-up has not been completed. There is a risk of nerves getting injured. For example, if you see the latissimus dorsi and serratus anterior, the most common nerves which can get injured is the long thoracic nerve of Bell. Then posteriorly, you can injure the long posterior and superior injuries of the ribs. You can get an injury to spinal accessory nerve, and any part you can also get injury to the lateral cutaneous branches of the intercostal nerve. Then injury to intercostal muscles, costal cartilage, and costal margin and diaphragm. Injury to the costal cartilage is very difficult to see through the CT scans. So what happens is, if there is a posterior rib fracture and if there is a splaying of the ribs anteriorly, then you should suspect a costal cartilage. Rarely you do a fixation, and when you don't want to do a fixation, you usually do a suture fixation for costal cartilage. Usually, a costal cartilage fracture is also it is simultaneous with intercostal muscle injury also. And for diaphragm injuries, you have to suture it you usually suture with the proline. Number 1, you have to do a suture repair of the diaphragm. Then moving on to injury to the lungs. Injury to the lungs, the most common clinical symptoms is a pneumothorax and hemothorax. The picture is, I think hemothorax is gone somewhere. So the most common clinical symptom is pneumothorax or hemothorax. Especially, the hemothorax is mainly caused due to the damage to the intercostal vessels and the internal mammary arteries. The presentation and evaluation, first you do an auscultation. You have to look for air entry. If there is suspected R entry is decreased, you have to suspect a flail chest, especially if there is a subcutaneous emphysema. You percuss the patient. If there's a patient is having a flail chest or if the patient is having tension pneumothorax, you immediately insert an ICD. So hemodynamic instability in a patient with penetrating thoracic trauma is virtually always an indication for operative exploration. So management of pneumothorax and hemothorax. Pneumothorax, so you have to immediately find it during a primary survey. You immediately insert a small bore ICD, a 22 or 24 French ICD has to be inserted. For hemothorax, the Eastern Association of Surgery of Trauma recommended that all hemothorax should be considered for drainage, regardless of the size. So some literature, they suggest that small volume hemothorax, that is less than 300 ml of hemothorax, can be managed just with without tube thoracostomy, without any ICD insertion, it can be managed. But the new recommendation that Eastern Association of Surgery is that any bleeding, you have to do surgery. You have to insert the ICD. For surgery, the operative indication is that if there is a bleeding of more than 1,200 to 1,500 ml of blood, or if there is 200 ml per hour for more than for 2 hours or 2 to 4 hours, then you need to go for a operative management. Next, what can happen during a lung trauma is the most common is the lung contusion. So here you can clearly see the lung consolidation and lung contusion. Usually the patient goes to a ARDS. The hallmark of this pathology is that the clinical symptoms and the radiological findings, they increase over time. They appear within 4 to 6 hours. And they evolve, the maximum at 3 days, it evolves, and most resolve within 1 week, the pulmonary contusion. The management of pulmonary contusion is judicious volume administration. Give adequate IV fluids, hydrate the patient, keep the patient in positive balance. Then you do a pulmonary toilet. That is, you see for any hemothorax, if there is blood in the pleural space, you have to remove the hemothorax. You have to solve it. Then supplemental oxygen. You need to maintain the saturation more than 90%. Either you can give a non-invasive positive pressure ventilation, and if the non-invasive positive pressure ventilation is not useful and if still the saturation is decreasing, then a mechanical ventilation is indicated if there is respiratory distress or failure refracted to less invasive therapies. So this is an indication, then you have to do a mechanical ventilation. Then the other thing is lung laceration. Laceration will often have large air leaks or less commonly hemoptysis. In lung laceration, lung laceration, if there is a large pneumothorax, bronchoscopy is a modality to diagnose any tracheobronchial injuries. Coming to lung laceration, I just want to show you an important, very nice case which we had last week. So last week we had a gunshot injury. A 17-year-old boy, he shot himself. Actually, he had by mistake, he was meddling with the shotgun. He just placed it just above his left, just superior to left nipple, and he shot himself with the shotgun. So here you can appreciate the open wound he had. There's a large open wound. He shot himself. Luckily, he didn't injure the aorta. Luckily, he didn't injure the heart. So, his life was saved, and that's why he could come to the hospital and he could get treated. So when we went inside, there was a huge laceration of the lung. You can see the lung was the upper lobe. This was the left side. Left side, you have only 2 lobes. That is the upper lobe and the lower lobe. The upper lobe and the lower lobe, there is a big laceration. So what we did was we just sutured. Normally when you suture it, the pneumorrhaphy, what we do is we use a 3-0-proline. First, so the pneumorrhaphy technique is first we do a horizontal mattress. We put we take a suture, a 3-0-proline. We do a horizontal mattress. We come to this end and then we close by continuous suture. So this is the technique of suturing the lung. So you do a sutures, you do a pneumorrhaphy, you do a suturing of the lungs and you do the repair. And after this, very, very important is you do a test called submersion test. We put a saline, we look for air leak and then we come out. So this was the findings. Here you can see the pellets, multiple pellets. This was the shell which we found. And this was some yellow thing which was found. I don't know what was this. GD sir, you can give some insight regarding this thing. I don't know what this is.
This is the packing. The cartridge of shotgun has a packing. This is the plastic packing.
Plastic packing, yes, sir. So this was actually the packing found. We actually, I didn't know what this was. We found this yellow color plastic thing which was inside. That also we removed it. So all these things were removed, and patient just got discharged yesterday. Then moving on to the surgical exposure. So a patient who's having a trauma like this, good surgical exposure. So patient either undergoes an anterolateral thoracotomy, or a clamshell thoracotomy. Anterolateral thoracotomy is like this. I mean, this is the sternum. At the inframammary crease, you give the anterolateral thoracotomy. If you give a bilateral anterolateral thoracotomy, it becomes a clamshell thoracotomy. Then a usual posterolateral thoracotomy sometimes is indicated, or median sternotomy. Only disadvantage of anterolateral thoracotomy is it is very difficult to assess the posterior part of the lungs. So that is a disadvantage. To access the posterior part of the lung, then posterolateral thoracotomy is indicated. If there is injury in the anterior part, then a median sternotomy is indicated. There is another incision called trapdoor incision, which was used previously. So it involves a median sternotomy, anterolateral thoracotomy, and a supraclavicular incision. So this is known as a trapdoor incision. Now it is not currently used. Previously, for thoracic trauma, trapdoor incisions were also used. For all lung trauma, I mean lung surgeries, we use something called, anyone can tell me what this spotter? What is this?
Double lumen endobronchial tube.
DLT, double lumen tube.
Double lumen endotracheal tube.
Double lumen endotracheal tube, perfect. So the advantage of double lumen, okay, so what are the types of DLT?
Right or left?
Right and left. And what is commonly used?
Only used for...
No, which right or left DLT, which is commonly used?
Depend on the injury side, right or left side.
That is used, but usually, I mean, there's a distal injury, you just want to put a DLT. You use a LDLT or RDLT? Okay, so we use something called LDLT. LDLT is very most common. I mean, why? I mean, the reason for using an LDLT is if you see the angulation of the right, I mean, there is increased angulation in the right side. Here it is more. Here it is an obtuse angle. So here to intubate the left main bronchus is much easier. So to insert a LDLT, that is LDLT is much more easier. You intubate the LDLT left main bronchus using the left dominant LDLT, the double lumen endotracheal tube. So here the advantage of using a double lumen tube is that either you can collapse any of the lung. For example, you're operating on the left lung, you can collapse the left lung, and you can just operate on the right lung. I mean, you can just ventilate the right lung and do an operate. You can collapse the left lung and operate on the left lung. So this is the advantage of using a DLT. I mean, this found only in higher institutes. So in lower institutes, they use something called bronchial blockers. So bronchial blockers, you intubate if there's a single lumen tube, you intubate either right or left, depending on the surgery. For example, if you want to operate on the right, you just intubate the left part of the left lung, and you use a bronchial blocker. So this is a bronchial blocker. You just block the right, whichever side you're going to operate, that side you use this bronchial blocker. In higher institutes, when you have this facility, you always use LDLT. So that you can also access. So most of the lung surgeries, we inflate the lung in between. We see for any air leak in between the surgeries. So it is better to use double lumen tubes. Next, coming to the surgeries in this, it follows damage control surgery principles. First is the pre-hospital, the ground zero stage. Next is in between stage 0 and stage 1, if there is severe bleeding, there is a stage called even REBOA, REBOA. Anyone who can tell me the full form of REBOA?
Resuscitative endovascular occlusion of aorta.
Balloon occlusion of aorta.
Balloon
occlusion of the aorta. So that is between ground 0 and ground 1. If the patient is severely collapsing, can use REBOA. Next is the stage 1 is surgery. Directly go for surgery. So the initial surgery, the damage control surgery, involves the control of hemorrhage. You need to control the hemorrhage, and if there is gross infection, you need to remove the infection. So what are the procedures which can be done is a pulmonary twist. So what is the pulmonary twist is if there is lung here, and if this is the lung, and if this is the hilum, you have the vessels here, you directly rotate this lung and you make sure that the bleeding is stopped. That is known as the pulmonary twist. Next, what you can do is hilar control. You go to the hilum, you just laterally move the lungs laterally, and then you control the hilar structures. That is the pulmonary vein and the artery. Okay, can anyone tell me what is the order of structures in the hilum? What do you find first? The vein or the artery?
Vein, artery, and the bronchus.
Yeah, exactly. So pulmonary vein, artery, and the bronchus. That is the order which you see from anterior to posterior. So you control these hilar structures. If there is bleeding, you go for it. Then there is pneumorrhaphy, that is you just suture it. Then there is staplers. If there is a gross laceration, you can just use multiple staplers that can do a wedge resection of the lungs if there is a laceration of the lung. Then intracardial pulmonary artery. So if there is a pulmonary artery bleed, you're not able to reach the hilum. It's all adhered everywhere. So there's a technique called intracardial. So we actually incise the pericardium. You go inside the pericardium. That is the origin of the pulmonary artery. You can just directly visualize the origin of the pulmonary artery. You can visualize the right and the left pulmonary artery inside the pericardium, and directly you have the control the bleeding by going inside the pericardium. Then the next common is the pack placement. You immediately, if there is a diffuse bleeding, if the patient is in shock, if there is diffuse bleeding, you place multiple packs. You just come out and reassess after 48 hours. So that is that are the different strategies in emergency thoracic trauma. I mean, you always follow the damage control principles. That is stage 1 is surgery. Then you go for a stage 2 ICU where you resuscitate the patient. You correct acidosis, hypothermia, hypocalcemia, coagulopathy. Then last is stage 3, that is the definitive treatment. The complications in this thoracic trauma is it can be either retained hemothorax, empyema, persistent air leaks and BP fistula, and chylothorax. These can be the complications. Retained hemothorax is, and if there is further bleeding, you have to go do it. Empyema, there are various stages of empyema. There are stage 1, stage 2, and stage 3. Stage 1 is, once again, stage 1 is exudative. You have 3 stages: exudative, stage 2 is fibropurulent, and stage 3 is organizing. Organizing is nothing but peel formation. So what happens is the parietal pleura and the visceral pleura forms a thick peel. That is organizing. So in fibropurulent and organizing stage, you have to go for a surgery. You have to remove the pus and come out. So these are the 3 stages of empyema thoracis. And next is persistent air leak and BP fistula. That is a separate level of management of air leaks. Initial small air leaks, you can do a bronchoscopy, you can plug it. There are also autologous blood transplantation for persistent air leak. And if nothing worse, you have to do a surgery. Sometimes you can do a flap. You can place an intercostal muscle flap, or you can place a LD flap, or you can even place a pectoralis major flap on the pneumothorax. And something also PC window. If nothing is working, you can do a PC window for a persistent air leak. Then chylothorax, if there's a trauma, if there is a injury to the thoracic duct, that can cause chylothorax. Chylothorax has 2 kinds of management. One is, non-surgical and surgical management for the chylothorax. So these are the various things which can, complicate in thoracic trauma. Thank you so much. I'll just stop sharing it.
Can we get video on for everybody?
Yes, sir. Video is on. You just have to swipe the other side, sir.
No. Mine video is on. I want everybody's video on.
Everybody, yeah.
Everybody, please put your video on. So, excellent presentation, Dr. Shyam.
Thank you, sir.
And I would, there are a lot of young boys here who want to answer certain questions since they have come prepared. Couple of things which I would, because it was a very long topic, he has summarized it. I will talk from general surgery viewpoint and from the exam viewpoint. So one important thing, I have noted some points. When it is a first rib fracture, besides what Dr. Shyam has said, when it is a question in the exam, they will show you a first rib fracture. What does this mean to you, Vijay Manohar? Besides what Dr. Shyam has said, what else you want to add?
Sir, first rib fracture means that the force of the trauma is very high, sir.
The better words you should use. Magnitude. Magnitude. Magnitude means both velocity and force, right? Then I would suggest on rounds, you get down into the culture of presenting your rib trauma with scarf score. Your management will improve. You will remember it by heart. When you write your progress notes, you write scarf score is 1, 2, 3 every day. Then Piyush Vasudeva, how would you order a chest X-ray for a minimal pneumothorax? How will you pick up minimal pneumothorax on a chest X-ray? Okay, if it is difficult, we have Jitu Yadav. You were there in the last class. Jitu?
Lateral decubitus position.
Pardon?
Lateral decubitus position.
Shyam doesn't agree with that. Anybody? Any volunteers? Saurabh? Vijay? Vijay Manor? You always order a chest X-ray in the extreme inspiration. But when you want to pick up a minimal pneumothorax, you should order at the end of expiration. Next question is, which location of pneumothorax is commonly missed on chest X-ray? Nandani? Colonel K.B. Prasad? Vijay? These are Viva questions. The examiner wants to know whether you are thorough with the subject or not. It is the anterior pneumothoraces which are missed commonly. Then I want to share a very useful method, not in the books these days, is titrating the dose of analgesic. When a patient comes to you with, say, rib fractures, and you want to give analgesic, a time-tested formula, as I was taught and as I have practiced all my life, we used to take 100 milligrams of pethidine in 10 cc of saline. Sit next to the patient. We didn't have mobile phone those days. We used to have our wristwatch. Keep your watch in front of you. Give 10 milligram of pethidine and wait for 3 minutes. You keep talking to the patient. After 3 minutes, if his pain is not relieved, give another 10 milligrams. After 3 minutes, give another 5 milligrams. A level will come where patient is alert, conscious, and his pain will disappear. That titrated dose, say, in a very strong built man would be only 25 milligrams of pethidine. Then you write on the chart, the titrated dose is 25 milligram. So after 4 hours, give only 25 milligram bolus. We have done it, a very large study over decades of giving IV Fortwin. You dissolve in 5 cc, 6 milligrams per cc, give 6 milligrams in intervals of 3 minutes. But first time you need to have patience. You need to have a watch in front of you. And then by my large experience says between 15 and 18 milligrams, all 70, 80 kg men become pain-free, given those 6 minutes to 9 minutes. Then next time, you give straight 15 milligrams of Fortwin. Patient is not sedated and is pain-free. Then there you can be asked, Vijay, where your friend has disappeared? He was here for a minute ago. Is he here?
Sir is sick actually.
Pardon?
He's not well, sir. From today, yes, sir.
No. What is his name? He was just now here.
Rakshit.
Huh?
Rakshit, sir.
Rakshit was well till I started the questions. Okay.
No.
We wish him good health.
Yes, sir.
Okay. We wish him good health. And who will give me 3 minutes lecture on multimodal? Dr. Prasad, can you tell us something about multimodal analgesia? This is a 5 marks question in DNB. You can't escape. So Piyush Vasudeva has volunteered to write a note on multimodal analgesia.
Okay, sir.
Then on displacement of ribs, fractures. When you take a fresh chest X-ray on arrival, you are likely to miss in a emergency room AP X-ray. You may miss 2, 3, 4 fractures, and the same fractures will appear very nicely by next day, day 1 of injury. It is not, Shyam, this for you. It is not that the movement of the patient in the ward leads to displacement of fracture. When somebody is injured, because of the pain, the muscles of the chest wall are in spasm. So they lead to splintage. They lead to the stabilization of the rib for a while. When there is analgesia given, patient is sedated, pain is relieved, muscles are relaxed, then those fractures appear wide apart. That is the reason, not the movement of the patient.
Yes, sir.
Never mind. We are all learning. I am also learning. And then I want to know Dr. Nagas, can you tell me what are the indications of rib resection? There are 2 types of rib resections. During access, we do subperiosteal resection of the rib. Under what conditions we remove a rib with the periosteum? Dr. Deva, Salvin, anybody? I want some volunteers. Resection of the rib with periosteum, indications. Vijay, you have been taught this so many times. Forgotten?
Yes.
Volunteers. If there are no volunteers, Shyam will tell.
Sir, following trauma or any condition?
No.
Sir, one I already told either 11th and 12th rib, which is sprinting, which is pressing on the, spleen, or whether it's causing injury. Second,
This is not in. Let me clarify. This is a separate question. This question has nothing to do with rib trauma.
okay, sir.
I am asking indications of rib resection with periosteum.
Second one is if there is any tumor of the tumor present, sir.
Very good. First is tumor of the rib.
Tumor of the rib, sir. Then when you want to do a window, sir, PC window, then you resect the rib also, sir.
No.
Along the periosteum, we resect the rib.
Okay, listen carefully. There are 3 indications. Number 1, tumor. Number 2, tuberculosis of the rib. Number 3, when you are removing the first rib. If you are removing the first rib for thoracic outlet syndrome and the rib grows back, you have the symptoms back again. Why do you do, Shyam, subperiosteal resection of the rib in renal operations?
I don't know, sir.
Number 1, to prevent pleural opening, because the lower margin The pleura is attached to the rib. Number 2, you want to prevent injury to the subcostal nerve. That is why we always remove the rib subperiosteally, except 3 conditions: tumor, tuberculosis, first rib. All right. Now, the costal cartilage is a very painful fracture, and it should always be fixed. Costal cartilage fracture should always be fixed, because that leads to much severe pain than any rib fractures. Number 2, the diagnosis is always clinical. When the patient is complaining of pain in that area and you gently palpate and there is a crepitus, that confirms the diagnosis. Number 3, Boss used to always preach. Those days we used to make thoraco-abdominal incisions for a lot of penetrating injuries. That used to be posterolateral thoracotomy converted into paramedian or midline. Boss was very touchy. He never allowed anybody to divide costal cartilage, costal arch. He said the lung complications sky high up when you divide the costal arch. And if we, under any difficult circumstances, had to divide, we had to fix it same time by drilling holes and figure of 8 wires so that it is a rigid fixation, right? And also block the intercostal nerves above and below through the chest. Then on the indications of surgical stabilization of the ribs, there is one. Now, there are 2 schools of thought. One, Dr. Shyam has elaborated. Lot of indications he has said. This is the matching reference is American school, especially all those who want to read more about rib fixation and things. There are 3-4 videos by Arizona Trauma Society. They will fix as soon as they see a fracture, they will fix it. But even 23 textbooks on trauma, they have a different vision. If a patient has got rib fractures with a significant contusion, when the contusion requires ventilation, am I making everything very clear? Rib fractures, contusion requiring ventilation. Now here fixation has got no role. Because if the contusion is going to require ventilation for 10-12 days, then by that time the fractures will get sticky itself. Am I putting my point clear? And if you look incidence wise, multiple rib fractures and flail, there are very few patients who do not have contusion and they have multiple fractures and flail. There's always associated contusion. Now there is a difficult question for Shyam. Define contusion.
So lung contusion is damage to the lung parenchyma, which leads to bleeding of the capillaries within the lung parenchyma.
This definition has got only one catch point. Today, everybody should remember. It is a non-anatomic, till you don't use the word, non-anatomic injury to the lung, which has blood, fluid interstitial fluid, serum leaked into the parenchyma, secondary to trauma. Otherwise, if you don't use non-anatomic word, then a pneumonia is also looking like a contusion. It is a white patch. Now, there are two types of, what is an occult contusion and occult pneumothorax? Shyam?
Sir, this is not picked up in an X-ray, but picked up only in a CT scan.
What is the relevance of a occult contusion? That such contusions are of lesser magnitude. They produce less of the respiratory symptoms.
Yes,
A
sir.
patient with multiple rib fractures on arrival, if his chest X-ray shows no contusion, but he is desaturating, assume he will have a contusion appearing from 6 to 24 hours. Contusions which appear spontaneously following injury are bound to increase by 24 hours. Then Colonel has disappeared. Colonel Saab is here. Dr. Prasad? Hello? Dr. KB Prasad? Unmute yourself.
Sir.
Hello, good
Sir.
evening.
Good evening, sir.
I heard you wanted to write a short note on contusions. You can be asked on the contusion, a X-ray, usually in Viva. Then they can ask you what is the mechanism of contusion.
Yes.
What is the fate of contusion? So a short note on contusion. All those who want to know more about thoracic incision, especially for Shyam, go through a video of an Indian. You know, the godfather, Indian godfather in American Thoracic Society is Dr. Manjeet Singh Bains in Sloan Kettering. His video on thoracic incisions is the best video. So you can have a look, share with your friends.
Yes, sir, definitely.
Then on pulmonary twisting the lung, hurriedly Shyam forgot to tell that before you want to twist the lung, you have to divide the inferior pulmonary ligament.
Yes, sir.
Lung cannot be. Chalo, koi baat nahi. That is the role of uncle. That is the role of uncle. You have to divide the inferior pulmonary ligament and then the lung can be twisted. Now, the last question is, though it will be discussed separately also, and this should go to Vijay Manor. Vijay Manor, what are the chest X-ray findings of empyema? All right, Shyam is there to help.
So there is fluid in X-ray. First,
there is not fluid in X-ray. There is fluid in the pleural space.
Pleural space. Fluid in pleural space. Then
Yes.
it can be associated with atelectasis of the lungs. There is usually empyema. It is also involved with parapneumonic effusion. So sometimes you can even see consolidation of the lung nearby.
No, we are okay. Let me clarify to make your life easy. You know, my role is to make your life easy. So Shyam, you are having a grade 3 empyema.
So here you have a calcification, sir. Peel. There is a peel and there is a calcification present, sir.
One.
Second,
Say, brother, say a thickened pleural peel
peel,
which may be calcified, like
which
that.
may be calcified. Yes, sir.
Then encasement of the lung, number 2.
Encasement of the lung.
Number 3. आगे बताओ.
Crowding of the ribs.
Crowding.
Very
yes,
good.
Very good.
Crowding of the rib. Very good. Dr. Prasad, you want to say something? There are only 2 more left.
Sir, in case of any association of pneumothorax.
No. Then you say associated pericarditis, associated this, that, nothing.
Sir, occasionally pneumothorax if there is anaerobic infection.
No, no. Occasionally fracture fee has fallen down. Okay, open your windows. The next point is shortening of the hemithorax. The next point is triangulation of the ribs or fibulization of the ribs. Have you heard about this word? Triangulation. The rib, the pleura pulls the attachment on the ribs. So the ribs becomes triangular in structure. Okay?
Yes, sir. Sir, only one thing which I want to mention, if there is a stage 3 empyema, many people, many places, centers, they go for medical management, medical thoracoscopy, but it never works. You should always go for surgical management. You have to go for a proper decortication procedure.
Yeah, you are going to have a full session on empyema. We will discuss it then.
Yes, sir. Empyema.
Right now, tell me the last point. Scoliosis with convexity to the opposite side. Now Vijay Manor will repeat.
Sir, there will be calcification present. There will be
there will be thickened pleural peel.
Thickened pleural peel, sir. There will be pleural effusion, sir, in the early stages, and there will be shortening of hemithorax, triangulation of ribs, and scoliosis with convexity to the opposite side.
I will also we will talk on this topic again, but these are few things which you are supposed to be hammered again and again. Now, what are the principles of treating empyema? Jitu Yadav. Vijay Manor, you are supposed to tell. You have attended thoracic classes so many times. 4 principles of treating empyema. Now I will complete all 4. Number 1, adequate drainage. Number 2, feed him like a pig, means adequate nutrition. Number 3, extensive physiotherapy. Physiotherapy is aimed, number 1, at lung expansion by means of incentive spirometry, mobilization of the shoulder joint to prevent fibrosis of shoulder joint, and number 3, lying with a pillow under the thoracic spine on the opposite side. If I have an empyema here, a tube here, I should lie on the side of the chest with a pillow here and lie like this, so that the crowding of rib doesn't occur and the scoliosis does not occur. All these are preventable things. Unfortunately, in no department In no thoracic department I have known taking care of the spinal deformity. Agreed, Shyam?
Yes, sir. I
You
mean, we
can
do all
spread
these
the-
things, physiotherapy, everything. Do this first time I'm live for scoliosis. Yes, sir.
Are you understanding?
Yes, sir.
So when you become head of department, you spread this message. Then I will, as a retired person, feel comfortable that something is being passed on, right?
Yes, sir.
Any questions so far on the red? Either Shyam will answer or I will answer.
Sir, in role of steroid in case of lung contusion, steroid or diuretics.
Diuretics have a role. Steroids have no role. The
Usually,
first
a
point
patient
is
having a re-expansion pulmonary edema, that time we give diuretics.
no. He is talking something different. He's talking about contusion.
Contusion. Okay.
In contusion, the first point is keeping the patient under hydrated. Don't overload the fluid. The worst contusions, Shyam, are when there are rifle injuries to the lung. Then it's all the mechanisms which Dr. Prasad is going to write. You know the mechanism of contusion, Shyam?
This parenchymal injury is a direct. It is a transmission of force, a blunt force to the lungs, sir.
No, sir. Maybe you read what is Dr. Prasad is going to write. In other words, how can you have a big bomb blast at the Pusa Road and contusion in Gangaram Hospital? Can that happen?
I mean, it depends on the pressure injury, sir. That primary blast, secondary blast. That is. It depends on
There
the
is a theory of
Short wave.
explosion,
explosion. Yes, sir.
implosion. See, there are three
That is the
mechanisms.
transmission of the waves, sir. The gaseous waves, which can cause
Shock waves.
Even sound waves.
sound waves. Which can cause.
So that is a blast injuries and firearm injuries. Are two separate topics to be discussed. Actually, for all you young guys, passing the exam of DNB is pretty easy. More so post-COVID. The examiners come to pass you only. Until somebody sits on the floor, he says, I will not pass. Until that situation arises. If you read 400 questions repeatedly, you can omit CTVS, pediatric surgery, plastic surgery, neurosurgery. Don't just tear off the pages from Bailey and Love, because all these things will constitute only 4 or 5 questions, and rest of 35 questions, if you can do well, you will pass. But passing the exam and knowing the specialty are very two different things. You cannot have name and fame without knowledge. Money will not come. You will pass the exam, you join ESI, work, get 1.5 lakh rupees, and keep a doggy and some flower pots and keep watering them in the evening. Time will pass easily. But what I'm trying to say, that there is no end to learning. We have to talk about, because when you have a patient and your contusion has got 3 causes and 2, patient is suffering from 3rd, as far as you are concerned, you know nothing about that patient. Anyway, keep reading. We will meet again. Now, as and when required, maybe sometime I can have, whenever I'm free, we can have a afternoon session also. But you should be willing. Last time I tried on a holiday. It was a holiday for everybody, but there were only two people, Kalman Prasad and Vijay Manor available. I'm sure all people, there was nobody operating on that day. But anyway, it doesn't matter. All right? Okay.
Yes, sir. Sure.
Thank you,
Thank you,
sir.
sir.
Thank
Thank
you.
you.
Good evening,
everyone.
sir.
Okay.